Radiology Conference of Ministry of Health and Population, and I'm happy to welcome you and start the musculoskeletal session. First lecture will be with Professor Lennart Jans from Belgium. He's a musculoskeletal radiology consultant and also a chair of the arthritis subcommission at the ESSR. And his presentation is imaging of sacroiliitis, current criteria and new techniques.
Okay. Welcome everybody. Thank you very much for joining this session, and thank you very much for the invitation to this beautiful country, which I really like. So I will be talking to you about imaging of sacroiliitis. We will discuss the current criteria and what new techniques are heading our way. So what we have to keep in mind when we image sacroiliitis is what we are actually looking for. So the golden bullet point, what is really important is that we look at inflammation of the sacroiliac joint, because this inflammation is a target to treat for our rheumatologists. And obviously in sacroiliitis you can get new bone formation. Some patients will not get new bone formation. But so mainly we have to look at the actual spine and the sacroiliac joints in order to find active inflammation. So what does a typical image look like? Well, it looks like this. We can see that there is extensive bone marrow edema on both sides and the iliac bone. And if you have a good look, then you can see that on the left side, on the top, you can see that there is a bulging of the capsule. So this is called capsulitis. So this for sure is a patient with active sacroiliitis. There is a definition of the ASAS, which is a very big society defining what we should look for, and they say that bone marrow edema is really important. If you see it, you have to report it, because that means that your patient has sacroiliitis according to the ASAS classification criteria. So just a few examples to get used to what we should look at. So here is another image. Again, we see this extensive edema. It is on both sides in the iliac bones, and depicted in red, you can see that there is the capsulitis, so the bulging of the anterior capsule. Of course, we can see this on CT images as well. So CT is perfect for structural lesions. We can see that there is sclerosis on both sides, and there's also erosions of the bone, so the bone was eaten away by the disease, and this is a very typical image of bilateral sacroiliitis in our patients. So when we look at axial spondyloarthritis, which is about 1% of the population, then the classification criteria tell us that imaging is really important. Right? So we have a really important role as radiologists, because the rheumatologists, they need to know if there is sacroiliitis. And there's two ways that we can say that there is sacroiliitis. Or we can do an MRI, and if on the MRI we can see clear bone marrow edema, clear active inflammation, then this is a sign of spondyloarthritis. The other thing that we can do is look at radiographs, and on radiographs we can also sometimes see very extensive sclerosis and erosions, and this is also a sign of sacroiliitis on imaging. So let's just go to clinical practice and have a look at what we can see when we do imaging. So when we do radiographs, we have to keep in mind that the rheumatologist wants us to state whether it's a grade 2 sacroiliitis or not. So what does this mean? Grade 2 means erosion and sclerosis. So when you make a report, you have to make sure that you mention these two things. Is there sclerosis? Is there erosion? So this is an example. So what do you think? Just have a look. Is this normal? There seems to be some erosion with pseudo-widening of the joint. And I do think that there is a bit of sclerosis as well, and this is seen on both sides. So this is a bilateral grade 2 sacroiliitis with erosion and sclerosis. What about MRI, the new technique that we all love very much? Well, I think that as radiologists we have a big responsibility to try and give the best examination possible for our patients. So we need to make sure that we use a T1 and a stir image in the semi-coronal plane. And we need to look at the entire joint, so not just the anterior cartilaginous parts, but also the posterior retroarticular parts should be looked at. And we scan all the way from the front to the back, so that we can see it all. So what should we be looking for? So we have obtained these nice images, T1 and stir in a nice plane. And there's two types of lesions that we should look for. We have the active lesions and the structural lesions. Active lesions are seen on the stir, or T2 fat set, or spare, or Dixon. It doesn't really matter that much. You can choose whatever is available. And structural lesions are best seen on the T1 weighted images. So the active lesions are bone marrow edema. We have capsulitis and enthesitis and inflammation of the joint space. Structural lesions include sclerosis, a band of low signal on all sequences. We have erosions, ankylosis, of course, and fat infiltration. Now this is the classic science. So what is new? Because this talk is about new insights. So this is, by the way, a very nice example of ankylosis. And here you can see that there is a very irregular joint. It has got a lot of erosions and some fat deposits just next to it. So what is new? Well, bone marrow edema is the most important feature because it's very sensitive. So this is something that you should always be looking for. Is there bone marrow edema present or not? Capsulitis and enthesitis may be present, but they will never be enough to convince your rheumatologist that your patient has the disease. Right? And we know these days that there is no synovium in the SI joints, so we call this joint space inflammation. Just a new terminology. What about the T1 lesions? What about the structural side? Well, sclerosis is something that we can see in spondyloarthritis, but it's also seen obviously in degenerative disease. So now we know that the likelihood ratio of your patient having rheumatic disease is decreasing when you see sclerosis. Erosion, on the other hand, is becoming another really important sign because erosion is very specific. There is no other diseases that will result in big erosions of the SI joints. So if you want to detect your patient, then you look for bone marrow edema because that's sensitive. But if you want to make sure that your patient has got spondyloarthritis, then erosion is the way to go because that's very specific. And then there is a new kid on the block, and this is called backfill, a very interesting new sign for us MSK radiologists. So basically, when you look at these images, T1 weighted images, you can see that in the joint space itself, there is high signal intensity. And that shouldn't be there. Normally, we have a bit of cartilage and a bit of fluids, so we expect a low signal intensity. But now we see a high signal intensity. And why is this? Well, this is the stage in between erosion. So we start with erosive damage, and then we have the filling up back again of these erosions, so backfill. And this has got a lot of protein and maybe a bit of calcium in there. So this is the intermediate stage with high T1 signal, which will evolve into ankylosis. So if you see this in one of your patients, high T1 signal in the joint space itself, well, this is very, very specific of your patient having spondyloarthritis. And something that I really wanted to point out, because this is what I see in daily practice very often, just a normal radiograph, we also see this very often. And if you look at this, the both sides of the hip, you can see that there is a cam deformation, right? So these patients very often, I don't know if I have a pointer. No. So there is the cam deformation. So on the sides of the hips. Now, very often people just say, okay, this is like a cam deformation, let's send this patient to the orthopedic surgeon. maybe he can remove the cam deformation and that's it. But if you have a good look at this image, not just the hips are abnormal, but also the sacroiliac joints. They are completely fused, they are ankylosed. So this is something that we shouldn't forget, that in spondyloarthritis or other rheumatic diseases, secondary, we have new bone formation, and so these cam deformations can be secondary to a rheumatic disease. So just keep this in mind. Oh, is MRI of the joint, of the SI joint perfect? Of course it is not. Right? So we can see bone marrow edema in early stages, but bone marrow edema will disappear if you treat it well. Bone marrow edema is easy to depict, right? So on the stir, everything is black and your edema will be white, but we know that not all bone marrow edema is sacroiliitis. Some other diseases may also result in bone marrow edema. And it has an excellent sensitivity, about 60 to 70%, but it's not perfect. So we need to be more specific. And there again, I would ask you to go and have a look at the T1 weighted images, because they will show you erosions and they are specific. Okay, so what about this case? You are the experts. There seems to be something going on in the right SI joint. There's a bit of edema there. So what do you think? Is this a patient with rheumatic disease or not? We can vote. Who thinks that this patient has got a rheumatic disease? Who thinks that they don't have? Who thinks that it's just impossible to know from this single image? Now I see a few hands, so yes, indeed, I agree, right? So this is a patient that had a previous MR examination 6 months before. So it's really important, especially in rheumatic diseases where you do the follow-up, that you know if some previous examinations have been obtained. So ask your patient if he had some examination somewhere, and ask your clinician to write down a lot of clinical details, because they will help you. On the left image, I just wouldn't know. It could go anyway. But now I know that this really was sacroiliitis, but that the treatment is working because the bone marrow edema is disappearing. Just a few differential diagnoses of rheumatic disease that we should take care of or know. There is DISH, right? So idiopathic hyperostosis, and there you typically see this anterior bridging of the joint, so it's like a little bulge that you can see. So this is not rheumatic disease, this is DISH, right? So you can see it there. So this is not to be confused with inflammatory sacroiliitis. Another one is psoriatic arthritis. So this is not spondyloarthritis, but psoriatic arthritis. Half of the patients will have skin lesions, so you can just go and have a look. And there we see a different type of osteophytes and syndesmophytes. So yes, we have sacroiliitis. It looks just the same like spondyloarthritis. But if you would do a radiograph of the lumbar spine, you can see these very bulky syndesmophytes. And this is very typical of psoriatic arthritis. It's a different treatment, so we have to make the difference between psoriatic arthritis and spondyloarthritis. Last one that I think is really important, when you see that the inflammation is crossing the capsule, right? When you see that there is not only bone marrow edema in the bones, but if it's also going outside of the joint into the soft tissues, then you have to be aware that this may be a patient with septic arthritis, which of course is a medical emergency. Okay, so now very short, some few exciting new techniques that are coming our way. And the first one is dual energy CT. Yesterday I gave a workshop here to a few of you, and there I was surprised that some participants didn't know about dual energy CT. So most CT units these days have it. So you can go back on Monday to your departments and do dual energy CT. It will be available on every CT unit from the last few years. So what we do when we look at sacroiliitis, well, so dual energy CT, and I'll try to explain this, allows for a post-processing algorithm for bone marrow edema. So if you have a patient that cannot undergo MRI, but still you want to see the bone marrow edema, then you need a different technique. So CT can help here. So dual energy CT allows to get rid of one type of tissue. So here we choose to get rid of the calcium. So we're not going to see the bone anymore, but we will see the bone marrow. And then there's two colors. The fluids will show up in green, and the fatty bone marrow will show up in blue. So this is the type of image that we get from CT. So you can see that the left SI joint has got very clear depicted green signal, which is fluids, and then the other side you can see that it's all blue, and this is fats. And so in this patient we also had an MRI, and I think that this does correspond quite well. So if you don't have an MRI, or if your patient has got a pacemaker, claustrophobia, whatever, then this may be a very elegant technique that you can use in your hospitals from next week, because you will have it on your units. And it may be very helpful for some other regions as well. Just look at this hip, right? A little bit hard to say whether something is going on this CT, but we scan all MSK in dual energy CT, so we can make the reconstructions. You can see that there is a lot of bone marrow edema, and on the MRI you could see the beginning of a stress fracture. So again, I think it's very beautiful and colorful images. Okay, what else is there? When we look at structural lesions of the SI joints, then T1, well, I think this is a nice T1 image, but sometimes it's a little bit hard to define whether there's erosions present or not. There will be a little bit debate in between radiologists very often. Now, there is a new sequence that you all have on your machines, which is called VIBE, and this is showing erosions a lot better because it really differentiates the cartilage from the subchondral bone plate very well. So we can see the erosions in a very, very nice way. So a VIBE sequence, just ask it to your MR technicians. You can just run this on Monday as well. Something else that we have been doing is using artificial intelligence to translate MR images into CT images. So the middle image here that you see is a CT image, and the right image that you see is an MR image that looks like a CT. So it's a synthetic CT image, but of course, in our young patients with sacroiliitis, we would prefer not to give a radiation burden, so we don't do CT, but now we can do MRI that looks like CT. So this is really nice and helpful. This is called bone MRI, and this will be coming your way hopefully in the next couple of years as well. So I know that it's a bit of a mind game because you think that you're looking at a CT, but this is an MRI. And this is a 3D MRI gradient echo technique, which means that you can play around with it. You can just do all kind of reformats, just like this one. And I hear you say, well, this looks nice, but it's not very helpful. Well, this is an MR image, so I think it's a little bit, well, it's just nice to see it anyways. But we can just cut away the bones, of course, because it's 3D, and now you can see the erosions in the expected anterior inferior aspects of the SI joint. And we all know that if we would project a CT in one plane, we get a radiograph. So we can do this here just as well. So this looks like a radiograph, but it's an MRI. Right? So we have projected all the points of the synthetic CT in one field, and this looks like an MRI. This does look like a radiograph. And if you have a good look and you look at the left side, you can see that there is a transitional anomaly. And our surgeons wanted to know, well, is there really an articulation or not? Well, we said, well, I mean, not a problem. This is 3D. We can just turn it around, and there it is. So this is an MR image showing the neo-articulation L5S1 very nicely. So my take-home points from this brief presentation would be that spondyloarthritis and rheumatic diseases are very common, so keep them in mind when you're making your reports. If you do a plain film, do not forget to include the whole pelvis, including the hip. MRI of the sacroiliac joint is really a beautiful examination, and I think that we need to do it well for our patients. So semi-coronal T1 and STIR is essential if we want to see the active and the structural lesions. Thank you very much for your attention.
Thank you so much, Professor Lennart, for this nice presentation. Very nice images indeed. May I have a question for you? What do you advise as a standard imaging protocol for screening patients with suspected spondyloarthropathy, and should we include the plain X-ray, the MRI, as a standard imaging protocol or for screening patients with suspected spondyloarthropathies?
I don't understand it because of the echo.
Oh, the echo, I'm sorry. So patients with, when we suspect spondyloarthropathy, what is imaging protocol, just as a kind of screening?
Okay, so the question was, so if you expect spondyloarthritis, so how do you start, what imaging do you do, and how do you do some screening? So I think that the best thing to do is start with a radiograph. It's very accessible, easy, and cheap. So just start with the radiograph of the pelvis, including the hips. That would be first. And then if you, the next step would be to do an MRI of the SI joints. Even if your patient has got pain in the thoracic spine, do not look at the spine, but go to the SI joints because they are very sensitive and specific.
Thank you so much.
Okay.
Any other questions?
Thanks, Professor Lennart Jans.